Thanks, Camille. As always, it is good to be here. I just caught the last slide and that you don't treat male pattern baldness at age 1. I didn't have male pattern baldness at age 1. Anyway, so I know it's winding down for everyone here. Last day of the course, last afternoon thereof, so I'll try to keep things moving. And there we go. Perfect. I put this picture in annually as an homage to the previous Children's Hospital sign. Now, of course, it's just called Cleveland Clinic Children's. And someday soon, there should be a sign on the new building on the other side of, what street is that, 90th, whatever. Anyway, so I'm going to talk about many things today, talk about orthopedic congenital problems, which include those things that happen very early in the first trimester with associated visceral problems, a sort of developmental issue where you have fetal arrest. For example, clubfoot is thought to be a fetal arrest, that the foot is progressing normally and then it stops unwinding. Packaging and molding abnormalities are part of the things that are truly congenital or present at birth. And certain things that happen at birth that are traumatic can be issues as well. Then developmental problems where there are genetic predispositions to a certain thing, late manifestations of fetal injury, packaging or molding abnormalities, which may become an issue not at birth, but a little later on. And then we'll talk about some traumatic and overuse issues. We'll start at the top, move downward. Torticollis is a sternocleidomastoid contracture, thought sometimes to be due to actually a little compartment syndrome within the sternocleidomastoid. Because of where the sternocleidomastoid originates and inserts, it will cause a classic head tilted toward and rotated away from the affected side. So because the sternocleidomastoid is behind the center of rotation, it will pull the chin to the opposite side and pull it down toward that side. Large babies and firstborn and those who have prolonged labor are all more predisposed to this condition, and high association with other packaging abnormalities, especially developmental dysplasia of the hip. Of course, the torticollis differential diagnosis is whether or not there's something actually going on with the spine, whether it's clipple file or some other cervical spine abnormality. By far and away, the majority of these people get away with physical therapy, stretching out the SCM, and not requiring any sort of muscular release. Those who don't have, however, full motion by year of age would be wise to pursue a lengthening. This is just a little cartoon of the sternocleidomastoid, and you can see a small human child in the lower right-hand corner with his chin away and ear toward the affected side. Clipple file syndrome, another cervical spine anomaly, is simply a congenital synostosis or fusion of one or several of the cervical vertebrae. There are typically some accompanying abnormalities of the GU, cardiopulmonary, or nervous system associated with clipple file. Something that's rarely seen but often tested, a condition called synkinesis, where you have involuntary mere motion of the upper extremities, which seems to be associated fairly heavily with children with clipple file. They typically, from the clinical standpoint, appear to have a short neck, a low hairline, and radiographically, you can see the fused vertebrae here, looking very early on like someone who has a degenerative issue in their neck. Sprengel's deformity is an asymmetric descent of the scapula. The majority of these are not treated clinically unless they have a, where do we get over there? Unless they develop a little or have a little what they call omovertebral bone attaching the scapula to the to the thoracic spine, which occurs in here. If it's simply elevated, a little bit of stretching sometimes is of use, counseling that it won't necessarily cause any dysfunction. Surgeries popular in the past to bring the scapula down have significantly fallen out of favor. Pseudoarthrosis, congenital pseudoarthrosis of the clavicle is not a birth fracture. It's something that always occurs in the mid portion of the right clavicle, is present at birth, may look like a clavicle fracture, but if there hasn't been a big deal in terms of birth trauma and you see a fracture, it may be this. Also, all birth fractures of the clavicle heal nicely and heal promptly. If you see a persistent fracture of the mid portion of the clavicle, even 6 weeks after birth, it may well be a congenital pseudoarthrosis. This is typically treated around age 5 or 6 with a little plate. If you do see it on the left, the only time it's been reported on the left, it's in association with situs inversus. Fun fact to know and tell. Other clavicular anomalies include, as we said, the birth fracture, typically from a difficult either vaginal or sometimes even C-section delivery. Birth fractures of the clavicle are typically a good thing because when the clavicle breaks, the brachial plexus typically does not get stretched. Moving down from the trunk to the extremities, a lot of arm and hand problems have corollaries in the lower extremity. But in most of the things that we're going to talk about, the upper extremities are typically more problematic because of dexterity. Congenital constriction band syndrome, I'm not sure why that was cut off, is a condition also known as amniotic bands, where they have circumferential constriction around an extremity. Curiously, the muscle typically does persist to a degree beneath, and typically the neurovascular structures actually do pretty well beneath that. And you can see in your mind's eye what those look like. I guess they're working. Super, thanks. Duplication of digits. You can see on the left hand, it's probably just sort of a large skin tag, whereas on the right side, there may be articular connection to the hand. There was a time when some of these were clipped off or tied off in the newborn nursery. We tend to do that a little bit less than perhaps they were done at one time, especially if the stalk is at all thick, because it can lead to some issues. So we usually wait till they're a little bit older and then excise duplicated digits. Same thing with the floating thumb, or pouce floutans. I just put that in there because I like saying that name. Syndactyly can be simple or complex, complete or incomplete. Whether it's simple or complex refers to whether or not the bones are connected, and complete or incomplete refers to whether or not the webbing goes to the tip. So here you can see that it is simple because it's not bone into bone, but it is complete. These need to be surgically fixed, which the time frame of when to separate these depends a little bit on which fingers are connected. The ring and middle finger do pretty well to be connected for a long time, but when it's especially ring and little finger, since the fingers are so different in length, there can be some long-term issues if they're not disconnected within the first couple years of life. Talking about in-toeing and out-toeing, which are common things that you'll see in your office, because I see them in mine as well. Typically, tibial torsion is seen as the chief source of in-toeing in those who have been walking under 1 year of age. Probably 98% will spontaneously improve to a normal foot progression angle as they walk after they've been walking for somewhere 12 to 18 months. For those children that you see a little later in life, typically after the age of 2, who come in with a chief complaint of in-toeing, it's most commonly femoral anaversion. Here you can see some siblings walking. They both have a negative foot progression angle, or that is, they're walking in-toed, but you can see from the little line on the patella that is pointing straight ahead on the little one, and it's squinting on the big one. And that's because the in-toeing on the larger child is coming from the femur, which the patella follows, and on the little one, the in-toeing is coming from a twist below the knee in the tibia. Here you see the south end of a northbound infant, and you can see that there's some asymmetry in the thigh-foot angle, and when you flip them like this, you can thigh-foot angle. I'm moving terribly well. But here you can see that when you take when you're essentially looking right down the tibia, what you're looking at is the rotation of the tibia. If you take a femur out and lay it on the kitchen table, and you look at the so-called version, you can see that the normal version in an adult is somewhere probably around 20 to 30 degrees. That's the amount, that's the angle that a line that runs up the femoral neck makes with the table. If it's significantly anaverted, as some children are at birth, you can see how in order to get this, the femoral head, into the socket, it has to rotate in, and that's what gives them their in-toeing. Knock knees and bow legs. Usually you see children who are knock-kneed. Usually see infants and young toddlers who are bow-legged in early infancy due to some lateral tibial bowing. And then early childhood, ages 4 and up, typically you will see more of a knock-kneed phenomenon. Here you can see both physiologic varus and physiologic valgus. Neither one of these children went on to require anything surgical. So this is the standard curve we always talk about. So at birth, they're born in about 17 degrees of varus. By about age 2, their legs are typically straight, and then they dip down here, usually somewhere around age 4, where they're in maximal knock-kneedness, and then by the time they're age 6 or 7, they have normal physiologic varus valgus alignment. And this was based on 1,480 measurements done in Finland back in the 70s. Now, not all angular deformity is physiologic. Obviously, there's pathologic angular deformity as well. You can get that from either physeal arrest or some sort of a traumatic malunion. Metabolic issues, most commonly rickets and renal-associated rickets, can cause angular deformity, both varus and valgus. Osteopenia, seen in osteogenesis imperfecta, and some of the juvenile rheumatologic abnormalities can give you a pathologic angular deformity, as can epiphyseal dysplasias and Blount's disease. This is a child with renal rickets, and you can see the wide physes, and you can see that one side's in a little bit of varus and one side is in a little bit of valgus. So moving from the appendicular skeleton to the axial skeleton, we'll talk a little bit about some spinal issues, starting with scoliosis. It's important to remember that scoliosis is a three-dimensional deformity, not something that's purely seen in the coronal plane. Though as a lateral curvature of the spine, anything over 10 degrees is what we use to define scoliosis. Most common scoliosis is the idiopathic variety. Congenital scoliosis, less common, implies not necessarily that there's a curve at birth, but that there is a bony abnormality which is going to cause potentially a curve. And then neuromuscular curves look pretty much the same as an idiopathic curve, other than the fact they're associated with some underlying neuromuscular disorder, be it muscular dystrophy, spina bifida, cerebral palsy, etc. Cartoon here of different sorts of congenital abnormalities which can lead to scoliosis. The worst scenario is when you have what we call unsegmented bar. You've got growth centers on this side of the spine, and on this side you have a tether. If you have a complete block vertebrae like that, that's unlikely to cause any problem at all. Here you can see a congenital scoliosis, and there's some little anomalies up here in terms of an extra little wedge vertebrae, and same thing here. And what's curious about a lot of these congenital curves that can be really pretty significant is that they often subscribe to the two wrongs make a right theory, where they've got a hemivertebrae on the left somewhere and a hemivertebrae on the right, and so whereas their spine wiggles a little bit between top and bottom, it overall has pretty good balance. So that's a good thing. Another favorite orthopedic word, diastomatomyelia, is associated with the congenital abnormalities. This is a spicule of bone or cartilage that splits the spinal cord, and as the child grows, the cord will be pulled a little bit taut, and typically will develop a little bit of a curve. A little hairy patch at the base of the spine is sometimes a telltale sign of underlying abnormality. So the idiopathic types, which are the most common, are arranged into three categories to make it easy for orthopedic surgeons to remember: infantile, juvenile, and adolescent. If idiopathic curves make up 85% of all curves, adolescent curves make up 85% of idiopathic curves. Once again, it's really important to remember scoliosis is a physical finding and not necessarily a diagnosis in and of itself when it comes to what is causing the curve. While most curves are idiopathic, it's important to remember that diastomatomyelia, spinal cord tumors, syrinxes, everything like that can also cause scoliosis. Which leads us to what are the indications for MRI screening in scoliosis. Probably all significant curves under the age of 10, painful curves certainly accompanied by neurologic abnormalities, curves which have unusual patterns or rapidly progressive, and sometimes we'll also do them on stiff curves preoperatively to try to sort out what it is about this curve that seems to be so rigid. So a little in situ question here. Scoliosis over 20 degrees in a skeletally immature, should it be followed? Should it be braced? We actually haven't talked about bracing yet. Cannot progress, will always progress, or usually requires surgery. This is sort of a pre-test. Good, correct. A, should be followed. Curves of 20 degrees don't need to be treated. We'll talk about that. And they don't necessarily progress. Treating scoliosis is typically anything under 25 degrees is observed. If you're still growing, a brace for those curves between 25 and 45 degrees is appropriate. And surgery begins at the 40-degree mark, and it's a little bit of a gray zone until 50, and then certainly at 50, I think everybody would agree that that's when you have a serious talk with somebody, while certain 40-degree curves, if they're particularly rotated or otherwise problematic, is certainly appropriate to fix. Now, bracing is for those curves that are between 25 and 45 degrees. The goal is to prevent progression. The curve will not permanently be corrected by the brace because the people being braced are growing adolescents. A brace is not something that people seek out, and therefore preserving household harmony while in the brace can be challenging as the parents scream, "You're going to be crippled if you don't wear this brace." And the kid says, "I don't care, I hate you." Nobody in my house was ever braced, but I just kind of always presumed that that's how it went. But anyway, part 3 is so to maintain self-esteem during the brace period. So I always tell patients to embrace their brace, let their friends try it on, take it with them to sleepovers, let other people, decorate it if you want, name the brace, George the brace, whatever. But bracing is certainly better than it used to be because the majority of curves can be treated with the Providence brace, which is a nighttime bending brace. As you can see here, if you had this on, you wouldn't be able to stand up straight. And that's because it's taking the curve and bending it the opposite way. Should bracing fail, or should the curve without bracing just end up in that 40 to 50 and up zone, operative management is appropriate. And the reason we fuse curves certainly over 50 degrees is because of those curves' propensity to progress after skeletal maturity in adulthood. And the goals of operative management are first and foremost to fuse the spine in the certain area where the curve is so that it doesn't progress. We certainly want to maintain or achieve balance if lacking preoperatively. Try to restore kyphosis and lordosis. The sagittal plane profile has been recognized more and more recently as critical to the long-term health of the back. Just because they look good on their AP view, they also need to look good on the lateral view because that has a lot of long-term implications for the unfused portions. And then, of course, people want cosmetic improvement. Here's just an example of a typical right thoracic curve. We're looking at a lot of people who are not orthopedists really hate it when they're looking at a chest film backwards, but we're looking at the patient as though we're looking at them from the back. So 76-degree curve, which was really quite flexible. And you can see here that it responded nicely to segmental fixation. And the idea, wrong way, wrong thing. The idea is to try to get some kyphosis and restore lordosis so that the end of the curve here, they're not leaning forward because that can cause a lot of long-term issues. Modern hardware does a nice job of derotating the spine, and you can see the rib prominence on forward bend pre and post-operatively. So moving from the spine to the hips, four little categories, three, DDH, leg Perthes disease, and slipped capital femoral epiphysis. Developmental dysplasia, also known as congenital dislocation of the hip. And a little pre-test, greatest risk factor for the presence of this, is it boys, is it high birth weight, breech positioning, C-section, or prematurity? Excellent. Yes, breech positioning. Whereas 1 in 1,000 hips is frankly dislocated at birth, with another 1 per 100 subluxatable or dislocatable at birth in general, nearly 1 out of 6 children who are frank breech, not necessarily at the day of delivery, but for a significant period of time during gestation, will have hip dysplasia. And the other risk factors include being female, a family history thereof, being firstborn, and high birth weight. So those of you who answered firstborn or high birth weight as the major risk factor, it is certainly a risk factor. The diagnosis is typically made on physical exam. The Ortolani test is a reduction maneuver. The Barlow maneuver is a provocative dislocation. Galeazzi is asymmetry of knee height when they are hips and knees are flexed. The so-called slide, as you're moving the hip around, if you feel it sort of sliding out up onto a speed bump and then back in, that's not a dislocated hip, but that certainly is a subluxatable hip, and certainly pistoning on physical exam is a sign that the hip is out. Asymmetry of abduction is seen later. And here is your Galeazzi sign with one hip presumably on the left-hand side. If they're dislocated, the femur appears to be shorter. Ultrasonography is a useful modality, but is not the way to typically make the diagnosis. The diagnosis should be made on a high index of suspicion and physical exam. It can be overly sensitive if overused. If you were to, as they have, do an ultrasound on every newborn, you may find a much higher likelihood of what appears to be a dysplastic hip, not necessarily an unstable hip, but a dysplastic hip. And therefore, most ultrasounds are probably best done after about age 6 weeks. After the age of 6 months, they're typically not terribly useful because as the femoral head starts to ossify, it becomes difficult to do an ultrasound. And this is just to show you how much of the hip is cartilage. Essentially, everything that you are looking at here is cartilage and therefore not visible early on with a plain radiograph. And the head early on is completely cartilaginous until it starts developing a secondary ossification center, typically around 3 months. So that's why radiographs can be misleading. Here, however, is a 9-month infant, and it's pretty clear that the right hip is dislocated. The number refers to something called the acetabular index, which is just an indication or a excuse me, a measurement of how much coverage there is in that acetabulum. This is the treatment of choice for the unstable hip, whether it's subluxatable, dislocatable, or dislocated. This is called the Pavlik harness, has a very high success rate. The main thing that causes failure with the Pavlik harness would be A, compliance, or B, the inability of the hip to reduce or go back into the socket when you put the child into the harness. So if it's an irreducible hip, the Pavlik harness is not used. This is what the radiograph looks like in the harness. Again, you don't see very much going on in terms of an ossific nucleus, or you don't see much going on here in terms of the acetabular growth, but we do see good symmetry, and so we know that the hip is likely reduced in the harness. Perthes disease is a transient avascular necrosis of the femoral head, reported most commonly between the ages of 4, some as young as 2, and if it's in teenagers, we call it late onset Perthes, and unfortunately, late onset Perthes has pretty much the same natural history as osteonecrosis does in adults, leading eventually to hip arthroplasty. It's more common in boys than in girls by almost a 5-to-1 ratio, and is bilateral 10 to 12% of the time, but never synchronous. In other words, you never have a hip that looks like he has Perthes at the same stage, both left and right side. Sometimes one will be a year, year and a half apart. No evidence for heredity playing a role. About 90% of these kids have a delayed bone age. Increased incidence in Asians, Eskimos, and Central Europeans. Ultrasound incidence, United States incidence is about 3 to 5 per 10,000 people. So a whole order of magnitude lower than DDH. There's interruption of the blood supply. How does this occur? We don't know why there's interruption of the blood supply. There's been some work done looking at blood viscosity, thrombotic events, etc. But in any event, the bone dies, new bone, osteoclasts and osteoblasts come in, take away the old bone, lay down new bone. What you try to prevent is collapse and deformity of the femoral head. Think of it as a piece of wet clay when it's undergoing the creeping substitution. Try to keep the ball in the socket so that as the wet clay, so to speak, is in there, it's kept spherical by being in the acetabulum. Diagnosis, oftentimes insidious onset of a painless limp. Kids will have a little spasm, atrophy, and maybe an antalgic gait. This is a representative radiograph showing what appears to be a big shark bite out of the hip. It's not that there is nothing there. It's at this point the bone has resorbed. It's mostly cartilaginous, therefore a little bit soft, and then new bone will come in there. So with time, they will improve, provided you can maintain the motion, keep them contained. Overall, prognostically, the younger they get it, the better they are likely to do. Kids who have onset of Perthes at 4 degrees, regardless of how much of their femoral head is involved, do 100 times better than someone who gets it at age 7 with even a small portion of their femoral head involved. This is what a healed head looks like in Perthes. You can see that it's a little, the femoral neck is a little bit short, the head is a little bit big, but in this particular case, really good congruity between femoral head and acetabulum. Likelihood of this turning into something arthritic and ugly when they're older is probably not any higher than anybody else. The slip capital femoral epiphysis is something everyone should be aware of. They can be acute, they can be chronic, they can be stable or unstable. The preferred nomenclature now is stable versus unstable, simply being unstable slips, patient can't walk on them. A stable slip, they can. Everybody in our Peds Ortho group this week received an email from some attorney up in Michigan who was looking for a plaintiff's expert witness on a kid who had a slipped capital femoral epiphysis that was pretty much missed for almost a year. And what happened was they went to see their orthopedic surgeon who didn't pay attention during his or her Peds rotation and mistook the knee pain, which is the most common presenting complaint of a slipped epiphysis, this sort of chronic knee pain, as some knee pathology. Well, they ended up operating on the knee and rehab, and they never examined, nor did they ever radiograph the hip. And what you want to see in kids who have this sort of sudden onset of limping or a little bit of medial knee pain is to look carefully at their pelvic views. The femoral head is held securely in the acetabulum, and as dehiscence occurs through the physis, right through here, this slips forward. So it's not really this is slipping off, it's this is slipping forward. That moves up. Epidemiology, now we're in the 10 per 100,000, so another order of magnitude from either Perthes or DDH, but again, this is something that you must have a high incidence of suspicion on to pick this up. Boys tend to be more frequently affected by this than girls. Most of these kids are overweight, like 50% of them are at the 90th percentile and above. Again, diagnosis being made on a high index of suspicion, history of, when did this start, habitus, medial knee pain. There's a branch of the obturator nerve that innervates the capsule of the hip, and it's this referred pain to the medial side just above the knee. That's the tip-off that there might be something going on that's not arising from the knee. Second part of the diagnosis is based on physical exam. They may limp, they may have an inability to bear weight. Certainly they will have a diminished ability to internally rotate, and they may have an obligate external rotation, even contracture of the hip. Then, of course, the gold standard of the radiographs, AP and frog view of the pelvis. Frog may not be enough if the motion is decreased, so you may need to get a straight lateral view. But the bottom line is don't miss it, be suspicious. Treatment options, typically one well-placed screw, like so, and it goes across the physis with the idea of causing the physis to close. Moving on to the feet. Clubfoot, congenital vertical talus, metatarsus adductus, and symptomatic flat foot deformities. The congenital clubfoot is a three-part abnormality of a tight Achilles tendon or equinus contracture, a significant amount of adduction, as well as varus of the foot. This is what an untreated clubfoot looks like in someone who's a little bit older, and that's why it's called a clubfoot, because left untreated, they walk on the side, and it really does resemble a bit of a club. Radiographically, they have a lot of parallelism of the hind foot, which is what gives it the abnormality. The incidence is back up there along with DDH. It's about 1 per 1,000 births. In certain groups in the South Pacific, the Maori, natives in the Polynesian region, up to 7 per 1,000. So clearly it's a genetic sort of thing. Males affected more than females, and bilateral involvement about 50% of the time. Multifactorial, depending on who in the family has it and how close they are, will make it more or less likely that the gestating child is similarly effective. It is not due to fetal packing. It's a developmental arrest. There's a difference between structural clubfoot, which is a foot that requires significant casting and sometimes surgery, versus the postural clubfoot, which is a packing phenomenon. The postural clubfoot unwinds very quickly to normal, maybe one episode of casting, but doesn't have the dense contractures that a structural foot has. And again, as I mentioned, it's thought to be an arrest of fetal development somewhere around the ninth week of gestation, when the child is still quite small for whatever reason, be it a perineal nerve issue or something controlling the ability of the foot to evert, it stops unwinding. Treatment starts with casting. Huge resurgent interest in the so-called Ponseti technique. Tremendous results with weekly cast changes when they're casted by someone who is well-versed with the technique. There's a lot less surgery being done now than there was 20 years ago, though probably 70% of kids still require a little lengthening of their tendo Achilles. The casting is typically, or rather always done in plaster, as you can get a much better overall mold on the foot. Congenital vertical talus is what gives the classic rocker bottom deformity and is associated typically with arthrogryposis as well as with spinal dysraphism, aka myelomeningocele. It's easy to differentiate vertical talus from just a severe plano-valgus foot by getting an x-ray with the toes pointed down. Congenital vertical talus does not correct, whereas someone who has severe clubfoot, severe flat foot will, with dorsiflexion and plantar flexion views, show that the talus corrects. Here you can see rocker bottom foot. Here you can see how the talus is sort of pointing directly toward the plantar aspect. Metatarsus adductus is mostly a residual of intrauterine molding. Treatment is dependent on the flexibility. If the foot is terribly hooked but very flexible, the prognostic likelihood of it getting better is very high. There is an association with DDH about 10 to 12% of the time. So if you're seeing a child in the office with significant metatarsus adductus, be it flexible or not, pay extra attention to the hips, because metatarsus adductus is found in association with tight fetal packing, DDH, increased tibial torsion, or all the above. I didn't really mention tibial torsion. But yes, all the above. So metatarsus adductus is this hook-shaped foot, and you can see it. See, it's hooked like so. Normal foot, the axis goes pretty much between the second and third toe, and whether it's mild, moderate, or severe, you can base it on static appearance or mild, moderate, severe based on flexibility. I prefer to do it based on flexibility. A very mild foot will correct to a valgus position. A moderate foot will correct to normal, and a severely tight metatarsus adductus foot will not correct even to neutral. So it's a severe feat that sometimes do require serial casting. Now, shoe wear is one of my favorites. I remember seeing my baby book, and the pediatrician wrote that it was important for me to wear high-top shoes, probably before I was walking. But shoe wear's most important function is it to provide ankle stability? Does it create an arch? Does it protect the foot? Or is it purely a fashion statement? Well, it's true, it is a fashion statement, but the most important function is to protect the foot. Most shoes really don't do anything for ankle stability, and an arch is not typically going to occur with or without shoes. It will occur with shoes or without shoes if it's genetically so programmed, typically between the ages of 3 and 5. So almost all kids who are walking around the municipal pool with wet feet on the concrete in the summer are going to give a pattern of no arch. Some kids don't really pick it up until age 10 because they're ligamentously lax. Pes planus in and of itself is not necessarily a pathologic condition. But clearly, shoe wear makes no difference in arch development. Very elegant study done in the British Journal of Bone and Joint Surgery back in about 1975, looking at thousands of shod and unshod children in India, where some kids wore shoes from birth, others never wore shoes, and they found that the incidence of hyperpronation and pes planus was not significantly different. There was a slight nod to the kids who never wore shoes as having better foot development. So I always check my car after this to make sure that the stride right people have not put a bomb beneath. So a few more issues of the spine that we can talk about. Backpacks and back pain. A lot of back pain, especially this time of year, we'll hear about it. Is it because my child's backpack is 3.6 times their actual weight? Book bags, really more than 15 to 20% of body weight do tend to cause a little bit of backache. They don't cause scoliosis, they don't cause kyphosis. And it may be impossible to limit backpack load to 10% of body weight, but that's my story and I'm sticking to it. Spondylolysis is a stress fracture of the pars interarticularis, which is the part between the facets on the posterior elements of the spine. Repetitive hyperextension typically is causative, therefore gymnasts, football linemen, weightlifters, divers, rowers, figure skaters, ballerinas, all are at higher risk than the average population since they tend to repetitively hyperextend. About 80% of these kids have tight hamstrings. This is an oblique view of the lumbar spine, and this is the pedicle, this is the superior facet of 5, the inferior facet of 4, and this little lytic area across here is the spondylitic defect. Treatment options. Treatment options are not this. Nobody puts anybody in a body cast anymore. Activity restrictions, non-steroidals, maybe a lightweight corset, muscle strengthening. Not that. Return to full activity typically in 3 to 6 months, if not before. Surgery is rare for this, only for significant pain and significant spondylolisthesis, which is a forward slip. This is a spondylolisthesis. You can see that the back of the vertebral body of 5 and the back of S1, there's a gap there because the pars has been interrupted and they've slipped forward. This is typically not an acute event. This is something that typically occurs over several years. Bless you. Treatment is most commonly conservative. 80% of people with a mild spondylolisthesis, not to mention a non-displaced vertebral body, i.e. spondylolysis, do exceptionally well treated just conservatively. Surgery is for those that are severe and unresponsive to conservative management, and this is what they end up with, a little posterior fusion, maybe something in the disc after they've been fixed. There are a few additional pediatric overuse injury slides in your syllabus, and I won't belabor any of those. They're primarily adult overuse injuries, which are unique because of the growing skeleton. Certainly, kids are playing one sport more than the old days where they played a different sport every season, and those repetitive sort of activities tend to create the overuse injuries that we not uncommonly see. So, if you have any questions, I'd be happy to take them over there. Thank you.